Well, hello everyone. Thanks so much for taking some time today in the middle of your day, probably in clinic or lunch, to join myself and Dr. Nora Lee Cothran. I'm honored to have you join me. Nora, why don't you tell everyone a little bit about yourself before we dive into what the excitement about this next 20 minutes is all about?
Sure. I'm an optometrist that's practicing in Largo, Florida. I'm at a secondary tertiary care center managing medical glaucoma and neuro eye disease. I trained at the University of Michigan, then SCO, and then Bascom Palmer, and now I get to care for patients with glaucoma.
Thanks, Nora. I'm really looking forward to this. My name is Justin Schweitzer. I'm an optometrist at Vance Thompson Vision in Sioux Falls, South Dakota, and I spend a lot of my time similar to what yours is, Nora, managing medical glaucoma, anterior segment disease, and looking forward to really a case-based discussion today. We're going to be talking about Vyzulta, as you can see from this initial slide here. We can go ahead and move to the next slide. And just so everyone knows, we are paid speakers presenting on behalf of Bausch and Lomb, who is sponsoring this particular program. The content is promotional. The cases are great, but they are promotional and developed by Bausch and Lomb. It's not a continuing education event, so you're not going to get any CME or CE for this. And then we do have to stay within the guidelines of what the U.S. Food and Drug Administration guidelines are. And so if there's anything off label, we won't be able to answer that. Next slide, please. Many of you are very familiar with Vyzulta. It's been around for about 5 years or so. It has a unique indication in my mind when I think about this. It's indicated for the reduction of intraocular pressure in patients with open-angle glaucoma and ocular hypertension. And why I say unique is it's missing a word. It's missing the word elevated intraocular pressure. And that really goes to their phase 3 clinical trials. Apollo, Lunar, we'll touch on that, Voyager, and then I think the most important one being Jupiter, and that's why that elevated is missing. And so it's a little different than a lot of prostaglandins that we think about. We look at the safety information like any prostaglandin. When patients are on this for extended periods of time, we want to talk to them about pigmentation changes of the iris, periorbital tissue changes of the eyelid, and some of these changes can be permanent. Like other prostaglandins as well, there can be gradual changes to the eyelashes, increased length, thickness, a variety of other things to the lids and lashes there. And then we want to be careful with any prostaglandin, even Vyzulta, when there's a history of active ocular inflammation, a history of past ocular inflammation, whether it's iritis, uveitis. And we want to make sure that if they have some type of iritis currently going or CME in the back of the eye, that we're not prescribing a prostaglandin. We can go to the next slide. I mentioned this already, but macular edema, cystoid macular edema can be exacerbated by prostaglandin analogs. So we want to be careful in those scenarios, especially with an aphakic patient that maybe has a history of CME or a ruptured posterior capsule. There have been reports of bacterial keratitis, and of course, that would be if the bottle tip touched the window of the eye. That can create some issues. Contact lenses can be utilized, but it shouldn't be utilized at the time that Vyzulta is being put in the eye, so about 15 minutes after administration. And then the most common ocular adverse events, as you can see here, conjunctival hyperemia in 6%, eye irritation in 4%, eye pain in 3%, and installation pain in 2%, a very small amount of patients. With that said, let's get to the fun stuff. This is what we're all here today for, and that's to talk about real-world cases. How do we help our patients? Nora, I'm going to turn it over to you. You're going to take us through the first case today.
Sounds good. Thank you, Dr. Schweitzer. So our first patient is a 53-year-old Hispanic female. She comes into my office, and she's been referred in from one of our, optometrists in our community. We know that as a primary providers of eye care in the United States, for a lot of patients, the optometrist is their entry into the medical system. So patients may have felt like they're perfectly healthy and happy for years and years, and then they have some issues with their up-close vision, and they end up going into their primary OD. Primary OD noticed that the optic nerves look a little asymmetric in this particular patient. She didn't have any significant medical history, and so they sent in for a referral. So let's go to the next slide. Let's see what this looked like. If you take a look here, she's best corrected to 2020 and 2025. CCTs are a little less than average. Her TM looks great on gonio. Don't forget to put a gonioscopy lens on all of your patients. Blow the dust off, find it. You can't tell if the angle is open or closed or what the appearance of it looks like without actually looking into it. And if you look here, there is some asymmetry in her nerve. These nerves are relatively similar in size. However, the CD ratio is asymmetric between the two. If you have a nerve where one's larger than the other, you're allowed to have a little bit of asymmetry in the CD as long as it actually matches and corresponds to the size of the nerve. So small, medium, or large, these both look like average size nerves, but notice in the right eye, you can see this in a little bit of a vertical elongation. And that's what the primary OD saw and said, you know, Mrs. Jones, something looks a little unusual. Let's get you to one of my colleagues that lives and breathes glaucoma. And so we could get a little bit more information. Next slide. These are what the scans look like. This is not unusual. You know, some patients, you can get an RNFL scan through your OCT and it shows all green. A lot of docs say, oh, green means good. No worries. I was a data analyst for the Department of Defense before I became an optometrist, and I like data. The more data that you have, the better you are able to help your patient. The beautiful thing about glaucoma is that you're constantly getting data throughout the whole time that you're caring for the patient. You're getting a little bit more information about what's going on systemically, what's happening with other factors that may elevate or decrease the eye pressure. And so this is just a piece of data that's a snapshot in time. And if you look at just the RNFL without doing additional scans or doing additional investigation, you might think, you know what, this patient, is fine. See you later. Nothing to worry about. We have the tools within our toolbox, these diagnostic capability to be able to get more information about the patient. One of those is the ganglion cell analysis. If you look on the right side of the screen, you'll see the GCA and you'll see what we call a classic wiper defect. It almost looks like a windshield wiper. Usually they're located inferior temporal in the right and inferior temporal in the left, almost as a mirror. Seeing this now, in addition to the patient noting that they had a possible family history of glaucoma, possibly her mother. She wasn't really sure at that time, but once she called her siblings and found out, you know what, before my mom died, she had to have some surgeries and some surgeries for some tubes. And when you start getting a little bit more of that case history, it really helps to guide your management. And I like to have an open conversation with my patients about what the risks are, what I'm seeing. When I look at this patient, I think this patient, there's no doubt in my mind that the patient has pre-perimetric glaucoma that's showing up in the scans. Next slide. But that may not necessarily show up in the fields. Patient's a great test taker. Glaucoma hemifield threshold is within normal limits in both eyes. And so in this type of a presentation, there's no right or wrong answer. There's an art and a science to managing this disease. And I think one of the art forms of managing the disease is to have the patient on board and to have them knowing what's going on with their condition, educating them, allowing them to make an informed decision and discussing it with you so that you're working as a team instead of you just telling the patient, well, this is what we need to do. Next slide. So that's what we did. You know, we talked about it. We say, you know, it really sounds like that the type of glaucoma that your mom had progressed so fast that you actually needed these tubes. You're very young and healthy. Right now, your pressure's starting off in the mid-20s. That's a little higher than average. I think that there's no downside to moving the pressure into a lower place. For patients that have these wiper defects, these are very pathognomonic for glaucoma and potential additional progression as you take those GCCs forward in time. The way that I explain this to my patient is, look, you're on a road trip. Glaucoma is like a cross-country road trip. And sure, we could throw you on a bicycle, just a regular generic prostaglandin, and throw you on a bike. I say, but if I've got the opportunity to throw you the keys to the Mercedes Benz, by all means, I want to put this medication on board. And the reason that this medication is so different than the other prostaglandins is that once the medication gets into the anterior chamber, it breaks into two. A latanoprost and also a nitric oxide working 100% in the outflow pathway of the eye. And when we put the patient on Vyzulta, she came back in 4 weeks. Next slide. We set the target to Aegis. And she was down to 16 and 17, right under where that target was. And so, you know, these patients, they respond very well to this medication. It's well tolerated. I don't get many callbacks about patients having red eyes or feeling irritated. I just, let them know, go ahead and, give this about 3 weeks. I do the follow-up at 3 weeks so that they've still got the sample bottle. And if it's working great, there's no downside to keep that patient in the Mercedes Benz. And I let the patient know, look, we've caught this very early. Your optometrist that sent you to me probably saved your vision. Stay with them. Annually, you'll stay with me and we'll both work together to keep you safe. Go ahead and we'll go to the next slide here. And I'll turn this over to Justin.
No, I think that case is great. It fits a lot of things that we think about, with glaucoma and Vyzulta. I think the first thing to comment on is, your assessment of the OCT. I think if that OCT didn't look the way that it did, that's a patient a lot of us would monitor. But because of that ganglion cell defect, agree. I think treatment is necessary. I think the other thing that this case does a wonderful job of is if we look at the Apollo and Lunar study data, which was the phase 3 clinical trial for Vyzulta. And you mentioned this, you set your targeted ages, right? We want a 25% reduction or more. A lot of us want 30% or more, right in that range. And we feel like we can really slow down progression. And we know in the Apollo and Lunar studies, when we look at Vyzulta being utilized in those studies, that we saw 90% of patients in post hoc analysis got an equal to 25% or more reduction in IOP, and 78% or so got a greater than 30% reduction in IOP. And that's what you saw in your case. And so the data fits the case, and you love data. You mentioned it, and
Data.
prime example of it. So thanks for that case. That was wonderful. I'm going to take us into case number 2 here, monotherapy switch from latanoprost. We'll see if we agree with that. The beauty of glaucoma, it's a very artful eye disease. We're going to talk a little bit about would we do that in this particular case or not. But we have a 54-year-old patient, male Hispanic patient here that presented for a checkup. This patient reported a history of open-angle glaucoma. This patient is being treated already with a generic latanoprost. Prior to treatment, it's always important to know what their Tmax pressure was. And in this particular case, it was 25. So his pressure before treatment was 25 millimeters of mercury. That history we talked about, he's got a history of cataracts and myopia, and then you can see his medical history there as well, and some of the other medications that he's on. So keep in mind, he's on a medication once a day in both eyes. Pre-pressure or pre-treatment pressure was 25. We can go to the next slide. Here's the ocular exam. So vision, best corrected, 20/25 in the right eye, 20/30 in the left eye. On examination with the slit lamp, he's got some cataract in the right eye and some dryness in the left eye. Pressure today, 21 in the right eye, 20 in the left eye. Remember, pre-25, 21 and 20. Nora, you did a great job talking about, well, where's my target? With this, based on this exam right now, you haven't seen fields or OCT, so I know it's maybe an unfair question, but is he at what you would expect for target from his Tmax?
I really would like this patient lower. I really think that, he may not be getting at the higher end of the curve of the efficacy of what the traditional, just normal prostaglandin, run-of-the-mill prostaglandins should be getting him down to.
Completely agree, right? I mean, we need to see the OCT, we need to see the visual field. We all know that. But if you just look at the clinical data and where he came from and where he's at, it's probably not ideal yet. And we can go back to that 25% reduction, 30% reduction, which was what we want typically with our PGAs. Corneal thickness on the thin side, again, Nora mentioned it. Gonioscopy, you got to do it. You can't diagnose without it. You can see it looks good here, open to trabecular meshwork. And then you look at the nerves, and you have pictures of the nerves in front of you, maybe a whisper of asymmetry, but fairly symmetric between the two. We can go to the next image. Here's OCT, a little different type of OCT than the one we looked at previously, but a few concerns here, specifically the right eye. We have a ganglion cell defect. Nora covered that beautifully on that last case, but we have one here as well in the right eye. And then we have some superior retinal nerve fiber layer thinning as well. And so both things affecting this patient's particular right eye. In the left eye, borderline with the RNFL, maybe some early superior thinning there. The ganglion cell looking very, very normal. So my biggest concern here, based on just this, is the OCT in the right eye, but does it match structure and function? We'll go and flip to the next slide. And you can see here, it matches very closely. If you look at that right eye, we have a nasal step that corresponds very well to the thinning we're seeing with the RNFL. It's also encroaching a bit centrally, which corresponds with what we're seeing with that ganglion cell defect. And then the left eye the field looks clean. And so again, probably pre-parametric or early glaucoma in the left eye. In the right eye, we would argue, depending on what type of visual field analysis you use and the way that you stage your visual fields, but I would argue that's a moderate open angle glaucoma situation in the right eye. We'll go to the next slide. So this patient, based on the diagnosis, of course, open angle glaucoma, right eye greater than left eye, does have some elevated IOP. We have some visual field loss, thin corneas, and IOP probably not at goal. I obviously care, is this patient progressing or not? I keep that in mind. I think that some people in the audience may say, well, I would want to get one more visual field since it's a brand new patient to me, to make sure they're progressing. I couldn't argue with that. I mean, it's an artful eye disease. I'd be comfortable if you said, I'm going to bring them back, get one more test. I think that's fair. I think based off where this patient's Tmax pressure is, and Nora alluded to this earlier and stated it wonderfully, I don't think we're where we need to be. And so I think it's very reasonable to consider a few different things here. One, being a switch from generic latanoprost to a brand name prostaglandin, specifically Vyzulta. Why would we do this? Again, goes back to the data. We have data from the Voyager study, a phase 2 clinical trial that showed that 42% of patients in that study on a switch from a latanoprost got equal to or more than 2 millimeters of mercury IOP lowering when they made that switch. Around 30% of patients got more than or equal to about 3 millimeters of mercury lowering. And so in this particular case, we want to take a patient from 20 to 21, and we really just want to get about 3 or so millimeters of mercury drop to kind of hit that target pressure, and then you monitor. Then you monitor to see if this patient is going to change or not change. Any other reasonable thoughts here that you would consider, Nora, in this particular case?
No, I think I like switches when I'm trying to get the pressure lower. We know as glaucoma specialists that if you start adding extra bottles of medication on board, then the patient compliance starts to go down. So even if the person's trying the hardest they can, they're trying to do the right thing, inadvertently, they're not going to be as compliant with 2 bottles of medicines. So as practitioners, sometimes it's just easier, especially if folks are in a practice where they don't have somebody helping them with prior authorization, things that they'll just add a second bottle. But remember, you're in the driver's seat of this disease helping this patient, and you get to make the decision. So for me, a 1-for-1 swap is a no-brainer because it keeps the bottle burden low and at 1 bottle versus adding on additional bottles.
That's such a key point, because I think of myself, I'm not a patient. I don't have to take any drops, but if you told me I had to remember to take 2 medications a day, it's a challenge. It's hard enough for me to take my vitamins in the morning. I do it, but it's hard. And so I think that's such a crucial point to make that switch. If it doesn't work, what are you out, right? You're going to see the patient back in 4 to 6 weeks. If it didn't get you to the target you needed to, now you have other options in your back pocket. You can move to that as well. Next slide, please. So this was the follow-up, initial pressure 25 in both eyes. When we saw the patient that day, 21 and 20, again, not ideal. We ended up making that switch to Vyzulta. The medication was well tolerated. They took it once a day. Saw them back about 4 weeks later, which is traditionally what we do. And you can see hitting that pressure of 17. Now we've hit that target pressure that we like. Does that mean the patient's going to be stable? I want to reiterate, not necessarily, but we're now at a target pressure that we were hopeful for. We've achieved that. Now you watch that patient, watch for stability. And as long as that patient stays stable, you keep them on that 1 drop a day for as long as possible. Next slide, please. So just in review, we talked about this earlier. Again, Vyzulta is indicated for the reduction of intraocular pressure for patients with open angle glaucoma and ocular hypertension. Nora and I covered 2 different scenarios. The patient that is a first-line agent or first-line option. I talked about a switch. I think, another study out there, the Jupiter study, you could use this in low baseline pressure situations as well. So there's really 3 unique and powerful ways to utilize it. Again, the important safety information, pigmentation changes to the iris and periorbital tissue that, again, can be permanent. Remember, eyelashes can change over time with the use of this. And then we want to be very cautious in anyone that has any type of intraocular inflammation, whether it's active or previous history of it as well. Next slide, please. The macular edema piece, again, if it's active, we want to be careful with that with prostaglandins. They have a history of a cataract surgery where they're aphakic or a torn posterior capsule. Careful to educate our patients how to utilize the medication because there have been reports of bacterial keratitis, mainly from the dropper bottle touching the window of the eye. It can be utilized with contacts, but not when the contacts are in the eye. So the contacts should come out. You can reinsert them 15 minutes after administration. And then the most common adverse reactions, we both alluded to this multiple times. It's a well-tolerated medication. There's conjunctival hyperemia 6% of the time, eye irritation 4%, eye pain 3%, and installation site pain 2% of the time. Next slide, please. There isn't a next slide because we get to wrap things up. Nora, thanks for taking this kind of rapid fire 20 minutes with me. I had a blast talking a little bit about glaucoma number 1, 2 cases, but also talk a little bit about Vyzulta, sharing some of the data around it. Thank you for your time today.
Of course. No, thanks for the opportunity. I will never turn down an opportunity to talk about my favorite subject. I think as optometrists, it's well within our wheelhouse to be managing this disease. And I just want our colleagues to feel a little more comfortable, a little more confident in taking that next step of taking the patient along on that journey, because you have the potential to be with them through their lifetime managing this, preventing them from future vision loss. So thank you for the opportunity.
Thanks to everyone for taking time out of their day, whether you're at lunch, in the middle of your clinic, to spend this 20 minutes with us. Definitely means a lot to us because I know we both have busy clinics. It's never easy to take time out of your day to do this. So thank you.